Hello, Kidney Warriors! James here from Dadvice TV, your online kidney health coach, and this is another episode of Dadvice TV Live. As a matter of fact, this is episode number 303. Now, for those of you that are brand new and joining us, welcome. Great to have you here. My name's James. I'm a kidney warrior like most of you out there. I was diagnosed with kidney failure, but I worked with my doctors. I got my blood pressure under control. I started eating better. I did everything that they said, and my health has improved overall, and I now feel better, and I don't suffer from any of the symptoms I had back then. Now, my kidneys, they're not fixed. I don't want you to think that, oh, James did something magical that fixed his kidneys. There isn't any fix out there, but there are things you can do to help put the brakes on the progression of kidney disease. And that's some of what we're going to be talking about tonight with my co-host. We're going to talk about the latest treatments, and he is excited to talk about them tonight. So let me go ahead and let you guys know who we've got here. He is the author of one of the best, if not the best, kidney book out there. Learn the facts about kidney disease. I wish every doctor who diagnosed a patient would hand them this book. It's easy to understand, easy to comprehend. It will take away so many of your worries by telling you what really matters with kidney disease. It talks about when is the right time to start dialysis for those few that get to the point where they really do need dialysis. This book is fantastic. You can go to the URL go.dadvicetv.com/book to order it. You could also go to your local mom and pop bookstore, show them some love, and order a copy from them. But that is my co-host, the author of that, Dr. Stephen Rosansky. Hey, Doc, how you doing?
I'm good, James. Great to be on your show, and I've got some really exciting stuff tonight. I am really pumped. You know, I stay up with the literature, folks, and I'll give you my background in a minute, and I'm going to give you the latest and the greatest for you, audience. So most of you, I think, are probably CKD3. We're gonna really dive right into it and give you some really, really good news. And especially good news for older folks. And James always asks me how to define it, but we'll get into that in a minute. I'm an older folk for sure. I'm 77, and so that's older, but we'll specify as we get into the talk. I guess James likes me to tell you my background, James, is that correct?
Yeah, because we always have some new people, and we need to help them understand why listening to you is so important and not some of those people selling woo-woo or pushing woo-woo out there with magic cures.
Yeah, it really disturbs me greatly to see how much money is wasted on things, and that's not even so bad when it's much worse when there are things that actually work which you're not getting. And what we talk about is science, things that have been shown to work, and we're going to dig into it. So my background is for over 40 years taking care of kidney patients. I started the kidney program here in Columbia, South Carolina. I've taken care of dozens or hundreds of kidney patients, dialysis patients. I still see patients at the free clinic. I also have done a good bit of my own research, original research. My research has been recognized as being outstanding. In one of my papers, which is very much about when to start dialysis, was voted the #1 game changer in nephrology in 2011. So I have published extensively, over 100 publications, and I wrote the book that James showed you because too many of you folks go on dialysis early when you don't need it, and I've seen horror stories like that of people getting dialysis that did not need it, and so many people worry about, are they going to need dialysis when they really don't have that worry? And a lot of that worry will be alleviated, I hope, in tonight's talk.
So fantastic.
Whenever you're ready, we'll dig right in. So, so we'll talk about, the cures. Everybody wants a cure. and we're going to talk about the cures, and this is amazing stuff. And we'll talk about ways to slow the kidney decline and not have folks out there die prematurely. We want to live as long as we can. We want to stay on this earth and enjoy life. So I'm gonna be quizzing James, and so we're gonna see how much how much
You
he's
always
learned.
quiz me. Keep it easy.
Okay, first, what is CKD3, James? And can you break it down for me?
So CKD3 is an EGFR, which is estimation of your kidney function between 30 and 60, correct? Or 59, somewhere around there. It's
You're good?
where most people are. Typically,
Yep.
there won't be any symptoms at
Yep.
that stage. You'll get diagnosed by your doctor, probably doing some blood work and some urine testing. And that means there's a reduction in your kidney function.
Okay,
So it's
well
not functioning as well.
okay. That may be, that last part may be wrong, but we're going to get into it. And I want to break it down.
Because if you're old, that's right. I forgot about older people.
We're going to break that down in just a minute. The older folks may not have kidney disease at the upper end of that 30 to 60. And so what the international docs have decided, these are specialists around the world, the experts, and I've been part of this expert group. They decided to break up CKD3 into two parts, A and B. Most of you are CKD-A, which is 45 to 60. And fewer of you are B, 30 to 45. We're going to get deep dive into it. And to have CKD, important. You've got to have two values less than 60. Most labs don't even bother to report values over 60 because they're not reliable, okay? And you need two values separated by 3 months.
Correct.
And James, you got the answer to this. If you're 3A, 45 to 60, when you get your labs done again, how many are going to be normal? Any idea?
Many of you are going to be normal.
1 in 3. So don't take one value. You need at least two values over 3 months. Now, the kidney docs decided EGFR is not enough for diagnosing and describing your kidney problem. What else do we need, James?
Protein in the urine.
Yay. Absolutely. Not enough docs are doing urine analysis. You folks out there with kidney problems, half of the docs aren't even checking urine protein. Say, doc, you check my lab. What about my urine protein? Doc, check my urine protein. Make sure your doc knows to check your urine protein. And the classification of the different types of stages is not just GFR, but also urine protein. And roughly speaking, there's 3 levels of urine protein. We're going to dive into this a little more. It's mild. Okay, the way to get the best measure of urine protein is not 24-hour urine, not even dipstick, which dipstick is not a bad screening, and we'll discuss that in a minute. And I recommend people getting dipsticks if you want to follow your urine protein. You can buy them on Amazon, urine dipsticks. The mild is less than 30, and it's very confusing. We don't use the metric system in the United States. We are so backwards. It's Liberia and Myanmar are the other 2 countries that don't use the metric system. Yeah, we have good company, but the rest. So we measure the urine protein by the urine albumin, and you send a little tiny sample. The lab will measure your urine albumin, which is a protein, and your urine creatinine, and that ratio, if it's less than 30, is mild. For those of you outside the U.S., it's different units. It's divided by 10. It's 3. Okay, less than 3. So then moderate is 30 to 300, or 3 to 30 outside the U.S., and severe is over 300. To me, and we'll get into this again in a minute, if you have a 200 level, that's pretty significant. And that to me is something to really pay attention to. 200 or 20 if you're outside the US. This is the albumin to creatinine ratio. Those of you who test your urine dipstick, if you're consistently over 1 plus, to me, you've got serious urine protein. If you've got trace, it's probably not necessarily significant because that can vary a lot. And if your urine protein is 2 or 3 plus, you have very serious problems. What's the commonest urine protein for the vast majority of your audience, James? It was 3A, 45 to 60. What do you think is the commonest level of urine protein?
None, I would guess, or trace.
Mild, none are mild.
No.
Mild. Let's say mild. 30.
Okay.
Okay, less than 30, and 2/3 of you. That's the majority of the people probably watching. 2/3 are probably going to have 45 to 60 mild urine protein. If you're 3B, right, 30 to 45, more likely to have some protein. About only 1 in 3 is going to have mild. So the 3A, and as you get further down, when you get to CKD 4 or 5, you're much more likely to have protein in the urine, which makes sense. It's like chicken and an egg. The protein is a predictor of losing kidney function. So people that have lost kidney function are more likely to have more protein. Now, do we ever have a GFR over 60 that means something, James? In what situation, if you've got a GFR? Go ahead.
If you have a lot of protein in your urine.
Exactly. So the stage 1 and 2, we throw it out unless there's significant protein in the urine. Now, we talk about the trend. We've said this over and over again. Don't get hung up on one number. And this is so important. There's another recent study. I get so excited with these people that actually measure your kidney function. They look at what the lab can produce by an equation, right? It's an estimate. That's eGFR. And then they do expensive tests to get the actual measure of GFR. And we see this in any study that's done. The number varies by 30%. That's enormous.
When you sent me that report, I was shocked when I read it.
Yeah. I mean, it's something that there's not a lot of papers that have tried to do this because it takes a lot of work. But know that your number can be inaccurate. And which patients, okay, just a real quick overview. The primary determinant of that eGFR, estimated kidney function, is what lab value on your lab?
Creatinine.
Creatinine, perfect. And the creatinine depends on what aspect of your body?
Muscle, your muscle mass.
Absolutely, James, right on. So if you are, for whatever reason, wasting muscle because you've been sick, and you could see that a patient's muscle is gone, people that have really extreme diets, very low protein, people that have heart failure or cirrhosis, and people with very high BMIs, these creatinine values are going to be even less reliable than the average person. And people with amputations, because obviously you lose part of your limb that has muscle. So
that's the easiest way to reduce your creatinine if you have your legs removed, but it's not going to help your kidneys. And I always use it as an example because people always ask the question, and we had Diamond just ask it in the chat, how do I lower creatinine? That's the wrong question. We don't want to chase creatinine because it's just a marker, and it's not the only marker, but it's a cheap marker to use in a blood test to estimate your kidney function. And like Dr. Rose said, it can be off by 30%.
Yeah. James, you're right on. There's another blood test that's more expensive. You're absolutely right. The creatinine is cheap. It's a cheap test. Every lab does it. It's called cystatin C. It's just another marker. And if you and your doctor are concerned about what's your real kidney function number, let them do a cystatin C, a GFR, instead of just doing the creatinine, okay? something to ask your doctor about. Let's dive right into the cures. The cures. There is a great study, and I'll tell you, I got so excited, and I sent it to James when I saw this study. Done out of Canada, and I know these folks in Canada, they are very, very good academic researchers. So here's what they did. They said, let's take a massive population of Canadian patients. But I want to tell you folks that Canadian patients are different than population in the U.S., and James can tell us why. What's one of the main differences between a Canadian?
The diet, the food.
No.
No?
Demographics.
I'm
Canada
not
is
sure.
primarily a white population.
Yeah.
We have at least 15, 20% of our population people of color. You have them in Canada, but less. So this is primarily for Caucasian folks, and we're going to get into African American and their kidney issues a little later. So what they said, look, let's take this massive database, and we're going to look at people's kidney function, and we're going to see what's the likelihood over 5 years that your kidney function is going to get better by 25% or get worse by 25%. You got that so far?
Mm-hmm.
You're going to see it. These people, are they getting better or worse? And this is again showing you don't get hung up with any one value. This is over 5 years. A little less than 1 in 5 of you that are CKD or CKD3 or 4, this is primary audience, you're equally likely to have your kidney function go up by 25% or go down. So you may have cures. People going down 25% is going to be like a cure, right? and it's just, I mean, they don't explain it. It's probably some of it's lab, but it's amazing that you're going to see your kidney function go to normal. So let's say you're 50 today. If your GFR is 50, you've got a 1 in 3 chance that in 5 years it's going to be over 60. Isn't that great news?
Hey, that's fantastic news.
This is especially if you've got the CKD3 with the mild or minimal urine protein, okay? But if you've got higher protein, less likely that you're going to be, quote, cured, all right? So if you are CKD4, you're much more likely to have the higher urine protein, the albumin to creatinine ratio. So maybe 1 in 10 of you will have that so-called cure, but you're going to still see it. It will occur. But for those of you in the CKD3 range with very little protein, you got a good chance in the next 5 years that you're going to have normal kidney function. I think that's the best news ever.
Now, if we could just figure out how to make that happen for everybody, then we'd have fantastic news.
Okay, now, how does age affect this business about getting cured, right? So what would you think? If you're older, would you have more likely to get that kidney getting cured or less likely? The younger folks, what would you guess?
I'm going to guess less likely because, muscle loss, things like that happen as you get older. So that's why I'm guessing that.
Okay, so this gets a little complicated, right? So so we're looking at 25% decline in your kidney function, or going on dialysis, which some of the people go on dialysis, or having so-called CKD5, less than 15, right? So if you're under 65 and you are 3B is 30 to 45 GFR, how many of you are going to likely progress? Maybe 1 in 3, okay? But if you're 85, only 1 in 10. So
Ooh, wow.
older folks, it's unlikely that you're going to have anything to worry about. And don't let your doctor start pushing you on dialysis because you're not needing it. Half of the people with CKD4 will have this progression, 25% lower or going on dialysis. If you're 85 and CKD4, only 1 in 20. So your risk is very low once you get to that age, right?
That is
Older
fantastic
folks,
news as I'm
yeah.
starting to get closer to that, older folks, as you call them.
So let's say you're 3A. You got most of your audience, 45 to 60. The likelihood of going on dialysis or getting to less than 15, right, on your GFR, what's the likelihood if you are now 3A? All of these people, how many out of?
It's going to be single-digit
It's
percent.
1 out of 10,000. 1 out of 10,000. If you're
Wow.
45 to 60. Don't worry. Be happy. If you're 3B, it's higher. Okay. If you're 45 to 60, it's definitely higher. It's 3 out of 1,000. That's still pretty low. Okay. And as James correctly stated at the outset, and everybody says, oh, I got CKD3. I must be sick from this. James was right. You don't get symptoms until you're at least CKD4. So whatever symptoms you have, unlikely to be related to your kidney problem. Maybe some 3Bs as you get closer to 30. Now, back to the age thing. I just actually took a trip, my wife and I, to Australia and New Zealand. Great country, great folks, great docs, and great medical care system. And they are smart and they are very reasonable. They don't overtreat you. They're not going to put people on dialysis early unnecessarily. Very unusual to happen there. Happens very commonly in this country and in a lot of Europe as well. And here's what they say. They say if you're over 70, get this, James, over 70, and your GFR is over 45, you don't have kidney disease. To them.
Yeah.
Over 70, over 45. In other words, you're 3A, they don't consider over 70 kidney disease. All right? And that's because we've discussed this in other shows. As you get older, you just lose kidney function. You're losing a lot of muscle, you lose a lot of brain cells, but you lose a lot of kidney cells. And the other thing about why older folks don't have to worry, and, and my patients talk about me because I tell them this, which is real. They say, you don't have to, I tell my patients who are in their 80s, I say, with CK, I say, you don't have to worry about your kidneys. You're going to die of something else. Now, they don't like to hear that, but
it's true.
real.
Your kidneys aren't going to be the problem.
It's right. It's called the competing risk of death. Are your kidneys going to fail and compete and get you to need a machine, or are you going to die of some other cause? Much more likely as you get into your 80s and 90s that you're going to die of something else. And that's why, the progression of going on dialysis in this older population is unusual. It's really unusual. So let's say you're CKD 4 or 3B. Let's say you're below 45, right? Mm-hmm. And you're under 65. Now, there's a certain number of people are going to die in the next 5 years, maybe 1 in 10. But if you're 85, half of you folks are going to die in the next 5 years. So with the same, less than 45 and CKD4, 15 to 30. So don't let your doctor push you, especially if you're an older person. If you're a young person, you got lots of protein in the urine, you're losing kidney function rapidly, I have no problem preparing you for dialysis. Makes sense. Older folks, don't let your docs push you on a machine when you likely don't need it. Quick mention about race. There's a new equation that takes race out of it. I'm not going to go deep into this now, but there's actually been a study that showed your true kidney function number is actually higher than what you get when you take the race out if you're an African American. Um, and there's a recent paper to explain why if you're African American, you may have 2 to 3 times the likelihood of getting kidney failure. And this was a great paper too. It comes from 2 factors. One, you're likely to get your kidney problem earlier. Most Caucasian people start having abnormal number, EGFR number, and again, it's just a number. Don't let it get you panicky. It happens later. In African Americans, it happens earlier, and they're probably more. So since they're younger, they don't have that competing risk of death. Younger folks are much less likely to die.
Yep.
So that's why more of the African Americans, they probably lose kidney function faster, and they develop their kidney disease earlier. So very important to take care of your risk factors, and if you are a patient with protein in the urine, to make sure you get what we're going to talk about in a minute, the right drugs. So the latest of the international kidney docs, they put out recommendations. Their recommendation for blood pressure, what do you think they recommend if you are a CKD patient? What do they recommend for a target blood pressure, James?
So has it changed from 120 over 80?
Less than 120. They're looking, if you can tolerate it. If you can tolerate it, and even without protein in the urine, if you are a younger folk with a CKD, even 3A, you're getting a higher risk of getting heart attacks and strokes and heart failure. So, you want to get that blood pressure, if you can, less than 120. If you're an older person, it gets dicey because you can fall, and you may get a fracture. So I get less aggressive with the older folks. But if you're a younger folk, 120, less than 120. Now, let's discuss the new drugs. There's a whole Dadvice where I get into these drugs in great detail. But tonight I'm going to give you some information that's going to get some of you say, oh, these new drugs, I got to get them. You do not have to get them, and I'm going to tell you why. Not everyone needs to get these new drugs, and they're expensive as hell. Okay, so when is your risk of either going on dialysis or having one of the hardening of the arteries problems, the big word atherosclerosis, hardening of the arteries, all the problems with your heart failure, heart attacks, strokes, all that bad stuff. That risk goes up as what, James? You know the 2 factors that get your risk to go up?
No.
You do.
I probably know them, but I can't think of them.
As your kidney function goes down, your risk goes up. The lower your kidney function, the higher your risk of getting either kidney failure or getting one of these bad events of the heart, the brain, the strokes, and so forth. So you need to know how big a risk you have. And in general, older folks don't lose their kidney function as quickly. They don't have as much protein in the urine. So, they're not at as high a risk of getting one of these bad things as a younger patient in general. So the old drugs that have been around over 20 years, 25 years, are what 2 drugs to slow decline? We talk about them every show.
The ACEs and the ARBs, very affordable and common drugs.
They are low cost. They're generic. And unfortunately, 1 out of 3 of you that need it gets it and stays on it. And these drugs work, but your doctor shouldn't be piddling around, especially if you've got moderate to severe urine protein. If you're in the 200 range or 20 outside the U.S. of the albumin and creatinine, you need these drugs. And they can decrease your likelihood of going on dialysis by up to 50%. They're important, especially when you have that high urine protein. But they're not critical for everyone, although I think if you tolerate them, I think you should take them because they're not just good for your kidneys, they're also good for your heart. So the international kidney docs, what they say is that if you've got significant protein in the urine, you should stay on the drug even if your kidney function declines. Mm-hmm. Very common. And they followed people whose kidney function declined, who really needed it because they had a high urine protein, and they wound up much more likely to go on dialysis. So, but if you are one of these people that has minimal urine protein and you've got a problem with the ACE or ARB or the other drugs we're going to talk about, they're not so critical. Okay? You can also get another problem with the ACEs or the ARBs, James, is what? Besides a drop in your GFR when you first start them.
Sorry, I was not listening. I was sitting here reading the comments.
The other thing these drugs can do is raise your potassium.
Oh, okay? That's right. Yep.
And there's ways to take care of that. But if you really need them, there's ways to stay on them, even if your GFR drops. So the experts say you can even drop by 30%, stay with it. So let's discuss that with your doctor. And then it's the same thing with the new drugs, which we've talked about on prior shows. And these drugs will eventually be just like the ACEs and ARBs. They'll be generic. They'll be cheap. But right now, they are extremely expensive. The first type of drug, and we've talked about this in prior shows, is what, James? The
SGLT2s.
Love it, James. You're on it. The gliflozins, like empagliflozin, canagliflozin. Okay, they're great drugs for diabetics, and most insurance companies will say, "Hey, okay, diabetic, we'll get you the drug." And these drugs, see, here's the thing, and this we're not going to talk about this show. Maybe next show we'll talk about the protein. Everybody gets obsessed with low protein diets. The research on anything that's going to try to slow your kidney decline, you got to use the standard therapy, which is ACEs and ARBs. Mm-hmm. So these drugs like the SGLT2s, they studied on people already on maximum of ACE and ARB. So if you add them to people with a lot of protein in the urine, you're going to significantly slow the decline of kidney function. And not only that, you're going to decrease your risk of death. They are very, very powerful drugs. They decrease your death from heart failure, heart attacks. So the International Kidney Doc Organization says if you're over 20, they haven't been studied with people with GFRs less than 20. If you're over 20 and you've got, let's say, over 200 or over 20 outside the U.S. of your albumin creatinine, right? High urine protein, you should definitely, it's worth the money. It's worth the money to get on these drugs. If you have heart failure, even without a lot of protein, it's probably worth the money because they could decrease your death from heart failure. And they also recommend them for people who have GFRs in the 20 to 45 range. Why? Even without a lot of protein, because as you get lower, your likelihood of going on dialysis starts going up. So let's summarize. If you are, the vast majority of you, you're CKD3, you don't have a lot of protein in the urine, you're not diabetic, don't obsess with these expensive SGLT2 drugs, or the next one we're going to talk about. You need to know your risk, and you need to know whether it's worth the money and the side effects of these drugs to go on them, okay? And the same thing goes for the GLP-1, the weight loss drugs.
Yep.
Okay, so the if you're a diabetic and you got kidney disease, these are the drugs you should be on. First, metformin, very cheap. Mm-hmm. And then the next one they're recommending is SGLT2s, which, hey, you got diabetes or kidney disease, insurance should pay for it. And then the third one, if your glucose is still not controlled, are these weight loss drugs, the GLP-1s, like semaglutide. These weight loss drugs, lots of research going on. There's massive amounts of money being made by the drug companies on these drugs. They're trying to see if they also slow decline of kidney function. It's not out. The research is not out yet. So diabetic, metformin, SGLT2, and then the GLP-1, because you should qualify to get it. And these drugs can decrease the protein in the urine, which in turn theoretically will slow your decline. The last group of drugs is the drug like James is on, the spironolactone, which is called an aldosterone antagonist. And these drugs have also been shown. The latest sexy drug is called finerenone, another extremely expensive drug. I'm good with spironolactone, which is cheap. If you still got so ACE and ARB to decrease the protein in the urine. Then the SGLT2 is the next one to add. And then if you still got a good bit of protein in the urine, maybe something like spironolactone. And those drugs that are aldo antagonists can give you high potassium. So just a little word of insight, SGLT2s can lower the potassium, so you can combine, mix and match these drugs. But here's the biggest problem, the cost. What's the cost for a month of the SGLT? We talk about them glibly, oh, just go get them. But the cost, again, that's why I'm saying.
Is it like $1,000?
For the SGLT2s or the finerenone, that new Aldo drug, which I don't think you should buy. I'm good with spironolactone. It should do the same thing. $500 to $700 a month. And these weight loss drugs, $800 to $1,200 a month. This is crazy. People can't afford it. If you're diabetic, you may qualify under your insurance. But again, talk to your doctor. How much protein you got in your urine? How low is your kidney function? What's my risk of really progressing? CKD3A especially, or even B with minimal protein, don't obsess about getting these really expensive drugs. Make sure you get your ACEs and your ARBs because they're cheap and they work. And here's something I thought was really, I'm quoting somebody else. Most heart attacks and strokes occur in people that have what kind of values of their cholesterol or their blood pressure?
I'm going to say both of them high.
They could be even in normal range. And the point that this person, and I like this, they say, generally, the lower the better. What do we mean by that? We've talked about getting your bad cholesterol down, getting your blood pressure down below 120. In other words, if you got risk of having a heart attack or a stroke or getting kidney failure, going on dialysis, you want to be as aggressive with these things as you can within reason. So get your bad cholesterol down and get your blood pressure below 120. Another paper I read was talking about what you patients out there have to say about your medicines. You're going to like this, James. These are actually quotes from patients. I have to pay for my medication, so I either settle for less expensive options or ration the dose. This is reality. I mean, we doctors, we prescribe stuff, but we don't really follow up to see if you're really taking the medicine. But this is reality. And again, don't obsess or waste money on expensive things when you don't necessarily need them. And don't forget, you can ask your doctor, hey, doc, this drug is costing me a lot. Can you give me a generic version? They work just as well in most cases. And they're dirt cheap. So ask your doc. Don't hesitate. And then another patient said, my knowledge of medication mostly comes from a peer patient who appears to be very knowledgeable. Please listen to me. Listen to James. Listen to people on James' show.
No. You listen to people I talk to, not me.
Right. Okay.
I'm not a pro.
But at least you're better than the average person walking down the street. Okay.
Yeah.
And here's another one. As an experienced patient, I sometimes stop or modify the dose of the prescribed medicine without referring to my doctors. If the doctors ask, I would tell them I'm in full compliance. You're not fooling anybody. Be honest with your doctor. Be honest with yourself. This is your life.
It's
Okay.
like when I go to the doctor, they say, "Are you dieting?" They know the answer from the scale, no matter what I say. I'm not fooling them.
All right. The last thing I'm going to mention, then we'll try to take a few questions. There's something that I'm excited about. It's called the poly pill. Have you heard of it, James?
No.
Okay. There was an article in the top journal, New England Journal of Medicine, came out a couple of years ago. They mixed together 3 different medicines in people who have had a heart attack. I can't tell you how many times I've seen people when I was doing clinical medicine, doing my clinics, who had a heart attack, who had a bypass, and the surgeon doesn't make sure you get on the right medicines after you've had that. And a lot of people start and stop the medicines. So they put 3 medicines in one pill. Aspirin, okay, this helps decrease your next heart attack. An ACE called Ramipril, okay, which protects the heart. And then a lipid drug, atorvastatin. And this study showed that you can decrease bad things happening after your heart attack by having these 3 drugs in one pill. The problem, and we're trained to not combine pills. What's the downside to the poly pill, James? What would you think is the downside?
Well, if you need one of those to be different,
Exactly.
yeah,
Exactly. You may need to titrate. So I think it's a great idea, and I'm looking forward in the future to having a cholesterol medicine, a medicine to slow your kidney function decline, like an ACE or an ARB or one of these other newer drugs, all in one pill. But I would take each of them and get you on the right dose, and then get you on the combined pill. There's only one of these in the U.S. right now, which combines amlodipine, a common blood pressure drug, with a prill. Okay, but they're going to be coming. So I think we want to leave a little time for questions, James. You
yeah,
want
I
to
would
put?
definitely love some combo pills because my complaint with pills, and I
Uh-huh.
am 100% compliant. I do not miss a dose. I do not skip pills. As a matter of fact, I just refilled mine last week, and they're like, "Oh, they'll be ready next week." I'm like, "No, no, no, no." I called and said, "No, no. One of them I run out of. I won't have it on Sunday. I need these pills to live." But my biggest complaint is some of my pills taste awful because there's so many of them. So I'm putting them in my hand and putting them in my mouth, and I try to take the water all at once at the end. So some of them are dissolving, and there's a couple of them that are just, oh, they're bad.
I Listen, James. I take a blood pressure, a cholesterol pill, and some other medicines. I take them all at once, but I take them with juice, so it'll disguise the flavor. Yeah.
Yeah.
So if you
No, mine,
better.
it's once I get my water, I take a sip, it's fine. They go down. It's while I'm going, opening every bottle, and I have this whole process. I open the bottle, take the pill, put the lid on, then I put the bottle in upside down. So I know if I forgot to mark it on my phone that I took them, I can look and like, oh, the bottles are upside down. What day of the week is it? They should be upside down because I alternate
Yeah. Well,
each
just
day.
get your packets. Get your Monday through Friday packets or month pack. And I believe it or not, James, I put 3 months worth of my medicine in these weekly packets. I do it in one shot, and then I see if I took it. It's Monday. Did I take my Monday drug, or it's Wednesday?
Yep.
That's the easiest way to do it. Somebody just came up with a great thing. They were talking about how much it's costing them to be on all these crazy
Oh,
drugs,
yeah.
and
Right here.
again, who was it? Yeah, this is in Falls River. That's outrageous. The question that I have for you is, well, first of all, is it paid for by insurance? And are you a person that really needs the expensive drugs? Okay, and without having your history again, um, just having diabetes, if your insurance will pay for the fancy drugs like the SGLT2s, the GLP-1, good luck. That's great. Um, but in terms of the other drugs that are, especially the finerenone, If you can get your doctor to prescribe spironolactone, it's dirt cheap. You know, you don't have to spend that $500. And again, I'd want to know how much urine protein you have and how high is your risk.
Yep. All right. There are tons of questions. We have so many people watching the live today, Doc, and
Okay.
lots and lots of questions. So anyone out there, type your questions in now. This is the best time to get them in there. And Doc is scrolling through all the chat. We've had a lot of comments, 162 so far that have come through, and he will find some questions to answer. Now, we did have a lot of people ask about the recent pig kidney transplant into a human. So 2 questions. One will be, do you have any thoughts on that? And just to let everyone else know, I am trying to get a hold of the people who did that to bring them on to talk about it and share their news on what they've been able to do so far. So hopefully that will be here in the future. You never know, though. What are your thoughts on it, Doc?
I think it's a brilliant idea. The problem for people that have kidney failure, that are on dialysis, and are waiting for a kidney transplant is we do not have enough patients, enough donors, kidney donors. If you are a healthy individual, people in your family, please have them give uniform donor cards. We need more donors. So we don't have enough donors. The people are a little reluctant to consider an animal kidney. It's great. We
I
have a
get it.
lot. We have a lot to work out. This is not happening anytime soon, but it's a good development. It's a wonderful development. The future is going to be miniaturized dialysis machines that you take with you, and that will be dialyzing you, 24 hours a day, just like your own kidneys, and transplanted kidneys from animals that will be tolerated, that you won't reject, that will have so we have no idea. Just because it's working short term, you don't know what the long term effects. So it's going to take a good number of years for this to work out.
Yeah, and someone asked me to get the creators of the bioartificial kidney, the people who are working on that, which is Dr. Shuvo Roy. He was on here a few years ago. I will be inviting him back this year to get an update on their progress, how they're working with that.
Yeah. All right. So I'll try to hit a few questions, James, if you want.
Yep.
So someone's at Beverly urine protein, same as correct. No, creatinine is a blood test. The urine test you can do on urine. You can get in the urine both creatinine and albumin. Those are 2 tests that are done on your urine. So so urine, you got to ask your doc, not just a urine dipstick, and make sure your doc, anybody with kidney disease out there, be sure every time you see your doc, what's my urine protein? At least get a dipstick and have him send it off to the lab. Get that albumin and creatinine. It's the key thing. Someone's talking about foamy urine, which is not a issue, doesn't mean anything. Foam is nothing. It's what your dipstick protein is. If it's more than 1 plus consistently, you've got significant protein. Or again, your doctor should do the urine albumin creatinine. That's the best measure of your kidney protein.
Hey, question for you, Doc, because I've seen it in here a few times. Is the protein you eat related to the protein that's in your urine?
No, not at all. Not at all. Although those of you who want to discuss protein, I think that's going to be my next show, the end of April or May. But no, that's not the case. Somebody here has a good question. Clydette, 71 CKD4, okay, and 19% function. Again, remember what I told you. You may actually get improvement in your kidney function. That 19% is not a fixed number. It's a rough estimate of what your number is. They want to put in a fistula. I would say that you should get my book and look at
She bought your book, Doc.
There's sections in my book that talk about how your doctor can predict whether you're going to wind up needing dialysis in the future or as we discussed, are you more likely to die before you ever need it? I would say, my personal opinion, they want to put a fistula in. My personal opinion is I would not rush into it, because I have seen people who get these surgeries, multiple surgeries, because they have lousy veins, and they get multiple surgeries that they never needed. Okay, so no rush into it. If you were younger, if you were a young person with a lot of protein in the urine, I'd be fine. I'd be going ahead with the AV fistula. And then the other thing is, Clyde, that look at the options for dialysis. It's not necessarily using the blood access in your arm. You could do it through your belly, called peritoneal dialysis. Discuss that with your doc, and it's in my book in detail. And you got so Hamad's talking about exercise is great. Can't go through a show without talking about exercise. It will lower your blood pressure. It doesn't have anything to do with your creatinine. You can actually theoretically get some muscle breakdown if you do extreme exercise. So but that doesn't really help your kidneys. It will help your longevity for sure.
But it doesn't hurt your kidneys. It'll just artificially, for a short period of time, cause your creatinine to be higher, so your EGFR to estimated lower.
Exactly, James. You're right. Someone's GFR, Shalda, went from 40 to 29. Haven't had any scans. Hospital in the UK still missed appointment. Well, yeah, you need to get follow-up. Again, make sure Shalda gets your urine protein as well as follow up on your kidney number. Sheila has a 60 GFR, now 40. And Jardiance, is that an SGLT2, I think, James?
Jardiance. Yes.
Yeah. So now 40. I don't know if you're outside the U.S. A 40 outside the U.S. would be significant. A 40 albumin to creatinine in the U.S. is still pretty mild. So I don't know, Sheila. I would say ACE or ARB would be first. The Jardiance, unless it's fully covered by insurance, would be a second choice because it's expensive. And Hamad's talking about sodium bicarbonate, and the latest research, unfortunately, did not show a benefit. It's thought that treating acidosis with bicarbonate could slow decline of kidney function. I think it's still a good idea if you have a low bicarbonate, you have high blood acids to be on bicarbonate, but that has not been shown to slow decline.
And that would be a 21 or lower, correct?
Say it again.
On your bicarbonate, it would be a 21 or lower.
Okay. Yeah. Good. That's right, James. Absolutely. Very good.
There's so many people out there pushing sodium bicarbonate, aka baking soda, as a cure, and they don't talk about there's a right time for it, and it's when it's below 21 on your labs.
Yeah. No. Yeah. I think it can be beneficial for people, even though it may not slow decline. It's still the jury's out. It may actually slow decline, but the one study that recently came out didn't show it. Shalda's got a high blood pressure, and 41. Your doctor needs to get you on the appropriate numbers of drugs, at a minimum, probably a water pill with what you're on, and you probably need higher doses of drugs if your blood pressure is really high. Very important to get your doctor to attend to that. So Vincent has a large prostate, and a very large prostate can actually block the flow of urine, and it's easily corrected. Your kidneys will be fine if the obstruction is relieved. Plant-based diet, Vincent. I'm all for that. We'll talk about diet next time. Renadil, I have no information on. I don't think it's worth the money personally. No real good science to it. This is Jennifer, 57-year-old with GFR 20. Now, again, all of the things we discussed tonight are important for you. And at 57 years of age, if your kidney function is definitely going 20 or less, it may be time to think about getting potential donors, kidney donors, and getting an access for dialysis. No risk, no relation between your fatty liver and your kidney. So Hamad in Kashmir, I am Muslim, wake up fasting. I can't see anything more here. Okay, so Diamond is 45 and a GFR 1518. You're definitely in the range of GFR where you need to start thinking about getting potential kidney donors, going on the transplant list, thinking about the type of dialysis that you may be best suited for you. My book describes that in detail. Microalbumin, sobriety television. Microalbumin, the albumin in the less than 30 range, not a significant thing because it varies too much. Being vegan is probably a good idea. I'm good with that. Someone from Australia had acute kidney injury due to contrast. Okay, so Eva, yeah, make sure. Okay, here's an important thing. James is a victim of this. We only have 3 minutes, so we can't answer. Eva, you can get a decline in kidney function severe. It's called acute kidney injury. That happened to James, and they wanted to put him on dialysis. That's what's happening with your husband. He may or may not get recovery after getting the contrast. Generally, newer contrast agents are not causing that bad acute kidney failure like it used to. But make sure, Eva, that your husband's kidney function is not recovering before they put him on permanent dialysis. And again, my colleagues in Australia have been good about not doing unnecessary dialysis, but you still need to make sure that it's not getting better.
Yeah. Well, we are out of time, Doc.
Okay. All right.
That was fantastic. I want to thank everyone out there. Please give the video a thumbs up. It helps more people find this information, and it tells YouTube that this is useful information. There's a lot of scammers out there coming after those of us with kidney disease, trying to push false information, sell us cures and things like that, and pills that'll magically fix things or flush or unclog our kidneys and who knows what. You know, I've seen it all. So it's Dr. Rowe. He sends me all sorts of emails like, can you believe this BS? Somebody's trying to push. But I appreciate if everyone could give the video a thumbs up. That'd be great. Helps it get to more people who are looking for helpful information like this. Thanks again, Doc, for being here. Always, always great to have you here. And I'd like to remind everybody, Dr. Rowe has a fantastic book, Learn the Facts About Kidney Disease. You can pick it up at your local bookstore. You can go to Amazon. If you go to the link go.dadvicetv.com/book, you can also get it from Amazon. But thank you so much for being here. And thank all of you out there on the internet who are part of the kidney community here, helping make Dadvice TV great. I will be back early April, which is a few weeks away, with renal dietitian Jen Hernandez from Plant Powered Kidneys, and we'll be talking about diet related stuff. Bring your questions for that one. And Dr. Rowe will be back after he takes a trip to Europe with his wife, enjoys probably some lovely food in France, and just has a great time. Oh, I can't wait till I get to retire and travel. That's my dream. Visiting all over Europe again now that I'm older and can have fun and can afford things. All right. Thanks, Doc. And thanks everybody out there. And I'll see you all in the next video. Bye, everyone.